Good afternoon again, everybody, and welcome to the second part of our OrthoRoCKs webinar series. This afternoon, we are graced by the presence of Dr. Rafael Bundoc, who is a graduate of the UPCM in 1987. He finished his residency in orthopedics in 1991 and served as a chief resident. He finished his fellowship in pediatric spine surgery at the Chinese University of Hong Kong and has fellowships in orthotics in the University of Hamburg in Germany. He also has a diploma on biomechanics from the University in Glasgow and has a fellowship in cervical spine surgery at Oxford University in 1999. He is an outstanding teacher, inventor, innovator, and artist, a true Renaissance man. He's presently a professor of the Department of Anatomy and a professor of spine surgery in the at the UP PGH. He's here with us to talk on low back pain, Dr. Rafael Bundoc. Welcome him, everybody.
Good afternoon. So for this afternoon, we'll be discussing a topic that usually takes a whole day seminar. So I'll be limiting my talk to a certain portion, and I've entitled my discussion for today as Making Sense of Low Back Pain. So let us start with two patients with low back pain, both coming with low back pain. One is a 49-year-old male, and as you can see, the discs of the patients are very nice. There seems to be no problem at all with this patient. And another patient on the right hand, and it's being covered by our faces, but there's a question there. How old is this patient? So you'll be surprised that this patient is only 27 years old. The other one is 49, the other one is 27. You can see the discrepancy of their disc pathologies. So it goes without saying that a large portion of probably low back pain is also affected by genetics. Whereas we know for a fact that there's a lot more than just genetics, and that will be the discussion point of our webinar for this afternoon. Now, my lecture outline will be very simple. First will be the glaring epidemiology of low back pain. Then a discussion of the anatomy that we have probably forgotten or plainly neglected. And then the deficient classification that hounds low back pain problem, and the clinical witch hunt that we usually do when we have patients with low back pain. Low back pain is said to be a syndrome. It is not categorized as disease. I mean to say that low back pain is a subjective feeling of a patient coming to us with problems of the lower back. But look at this. M54.5, low back pain, G89.29, chronic low back pain, are classifications under the ICD-10 or the 10th edition of the International Classification of Diseases. I mean to say that M4.5 and G89.29, low back pain and chronic low back pain, are billable, specific ICD-10 code that can be used to indicate a diagnosis for reimbursement purposes. And mind you, the ICD-10 is a 2018 edition, and it only became effective in October 1 of 2017. So that already runs a discrepancy as to what the definition of low back pain is. They say that it is a syndrome, and now we find that low back pain is categorized as disease already. Now, let's go to the epidemiology. The source of low back pain is mechanical in 90%, and the prognosis is good. A lot of patients, 50% of them, are already okay after 1 week, and 90% have resolved within 8 weeks. So that's a very good thing for most of us. Now, less than 5% of patients with chronic low back pain progress to chronic low back pain, and that is what we want to prevent. Low back pain is second to upper respiratory tract infection as a symptom-related reason to visit a physician. In actuality, low back pain ranks something like number 3 or number 4 as the most common outpatient department consult for orthopedic cases. Chronic low back pain cause is comparable to coronary heart diseases, diabetes, and depression. Adult without subacute low back pain, mean to say pain more than 4 weeks but less than 12 weeks, are thought to be at risk of developing chronic back pain, one that we always want to prevent. Lifetime prevalence of non-specific common low back pain is estimated at 60 to 70% in industrialized countries. The one-year prevalence is 15 to 45%, and the adult incidence is 5% per year, meaning to say that every year there will be about 5% new cases happening, and the prevalence is about 15 to 45%. The prevalence increases and peaks between the ages of 35 and 55. 35 to 55 are our very productive years, meaning to say that it will entail a lot of cost with regards to the economy of any nation. Now, 62 to 80% of the normal population will experience a disabling back pain in our lifetime. If this doesn't scare us, I don't know what would. But mean to say that all of us are not immune to developing low back pain. And at 80%, it is quite such a high number for us to neglect. If you look at the incidence of low back pain in Asia, comparing China, India, Thailand, Vietnam, Malaysia, Indonesia, and the Philippines, you'll see that the Philippines ranks quite very high in terms of national prevalence at 21%. As you can see, for a very industrialized country that is already becoming a superpower, China is beset by a lot of patients consulting for low back pain, which is 64% prevalence. Now, diagnostic evaluation of low back pain is quite difficult. The anatomical diagnosis is always very elusive. Diagnostic evaluation is often frustrating, even with a lot of imaging techniques that we have. And there's always a useful question to the answer. Is this secondary to a systemic disease? Is there any social or psychological distress? Or is there any neurologic compromise that may require surgical evaluation? You might notice from the outline that I have given, I didn't mention any treatment at all. I will not be discussing treatment for low back pain because that is a webinar by itself, whether it is surgical or it is conservative. But as I go along with my lecture, I will be discussing some salient points of how we treat our patient and the logic whereby it works. First, what causes low back pain? Perhaps the best way to answer this is to look back at the anatomical basis of low back pain that probably we have forgotten or probably we have neglected. First and foremost, this is your spine. When you have a spine in a standing erect man, the line of gravity passes almost through all the anterior elements of the spine, meaning to say over the vertebral body. Much more so, it passes or dissects the vertebral body, the cervical spine, and that of the lumbar spine, and it is very much anterior to the thoracic spine. The center of gravity is about 4 centimeters or 2 inches in front of S2. Having said this, you will find that when you look at the spine, there will be 2 anterior elements. There will be the anterior elements and there will be the posterior elements. The anterior elements are the vertebral body and the discs and all the structures connecting it, meaning to say the ligaments and the periosteum. Then there's a demarcation at the back of the vertebral body, which is the posterior longitudinal ligament. All of the other structures past the posterior longitudinal ligament will be considered posterior elements. And in standing erect human being, where we usually develop low back pain because of gravity, the forces of gravity or the forces of the body passes 80% anteriorly and only 20% posteriorly. I want you to remember this because it's going to be critical in our discussion because any disturbances in this distribution, we could say if 80 minus 10 goes to 30 over the posterior element, then that will already predispose a patient to the possibility of developing low back pain. Now, the intervertebral disc is the centerpiece of the spine. We have to remember, though, that when we talk about the spine, we are referring to the architectural osseous structure that protects the spinal cord. But of course, when we discuss the spine, we cannot help but also discuss the spinal cord in a short while. The discs are made up of 2 structures. We have the annulus fibrosus and the nucleus pulposus. It is meant for shock absorption, and it is a joint. It is categorized as an unpaired shoulder joint. As you can see from the picture there, where the forces are being shown, there's a yellow line, there's a blue structure over here, and that blue structure there is a hyaline cartilage. The hyaline cartilage is the one that contains the nucleus, no? That's why it's a very, very strong structure. They say that the fibrocartilage or the intervertebral disc is a vascular, a neural, and a lymphatic. We need to say that it has no blood vessels, it has no nerves, and it has no lymphatic system. Correct. That is in an adult. When we were born, it is very, very vascularized. By the time that we got to the age of 8, the blood vessels starts to wither. And at the age of 11, the annulus is almost devoid of any blood vessels anymore. However, there's still nervous innervation as I'll show in a short while. Now, with regards to the blood vessel, that's another thing that I want you to remember, aside from the fact that I want you to remember that 80% passes to the vertebral bodies or the anterior elements. because in this degeneration, they found out that there is a revascularization of the annulus that has to be avascular already by the age of 11. Now, let's go forward. What is the maximum physiologic load between two vertebrae and the disc? They found out that in a vertebral unit, and when I say vertebral unit, we are referring to just two vertebrae with a disc in between. This is also called the biomechanical unit, or what we call a functional unit. And this unit is what they use for experimentation. They found out that a single functional unit composed of two vertebrae with a disc in between can sustain a maximum load of 245 kilograms. And that is in cyclic physiological load. Meaning to say that as we walk, the forces being borne by the functional unit is so strong at 245 kilograms. And in a normal person, this is subdivided into about 33 vertebral units over the whole spine. Now, what does it take to destroy a vertebral unit? And if you have so much force, which one will be damaged first? Is it the disc or is it the vertebral body? Experiments have shown that if you subject a functional unit to so much weight, and shall we say something like 612 kilograms, the first one to break will be the vertebral body and not the disc. So it shows from all experimentation that the intervertebral disc is much, much stronger than the bone itself. That the bone will fracture first even before the intervertebral disc gets damaged. And if you want to damage the intervertebral disc, you have to have additional weight, and that will be something like 800 newtons or 816 kilograms for you to be able to really fracture and obliterate the bone and macerate the disc already. So from this experimentation, which was done since 1966, 1972 to 1982, all studies have shown that the intervertebral disc is a lot much stronger than the vertebral body. So from these studies alone, you have to realize how important the biomechanics of the spine is. Now, when we talk about the disc or the spine is a multi-ring joint system composed of static stabilizers. And when we talk about static stabilizers, we are referring to the bone, to the intervertebral disc, and all the ligaments that attaches it. Okay? And when we talk about the dynamic stabilizers, we talk all about the muscles attached to the static stabilizers. With adequate experimentation, they have found out that the static stabilizers only afford 30% of the total strength of the whole spine, and that the dynamic stabilizers are the ones that afford the 70% strength for the whole spine. Ergo, if you were born with a weak spine, meaning to say that your static stabilizers are weak because of congenital problems or because of osteoporosis or because of your constitution was genetically weak, then we don't have to fret because we can strengthen our dynamic stabilizers to take over for our deficient static stabilizers. Meaning to say, just like in the knee, when you have an ACL injury and you do not want to have surgery, then you can strengthen your dynamic stabilizers, your quadriceps, especially your hamstrings, to take over the deficient ACL to have a knee that is strong enough for you to be able to walk on. And with the spine, you can also increase or strengthen your core musculature. You can do adequate physical therapy so that you can strengthen your dynamic stabilizers to take over for a deficient static stabilizer that is causing your pain. So with this alone, you can see why a lot of conservative management still has a very, very big role in the treatment of low back pain syndrome. Let's move forward. What are the pain-sensitive and the non-sensitive structures of the spine? This is a usual question that is being asked of residents during conferences and during exam. Let's start with the vertebral body. Is the vertebral body pain-sensitive or non-pain-sensitive? The vertebral body per se is not pain-sensitive. However, the periosteum around the vertebral body and that of the posterior elements are very, very pain-sensitive, as well as the anterior longitudinal ligament, as well as the posterior longitudinal ligament, and very much so the supraspinous ligament and the interspinous ligament that connects the spine. Now, when we talk about the intervertebral disc, is it pain-sensitive or pain-insensitive? We very well know that it's avascular. That's why the intervertebral disc, especially the nucleus pulposus, is non-pain-sensitive. However, the posterior annulus, the annulus fibrosus found posteriorly, is found to be very, very pain-sensitive. And lastly, the facets. Are the facets sensitive? Well, they are joints. They are diarthroidal joints because they have hyaline cartilage on both sides. They have a capsule and they are richly innervated. That's why the joint or the facet joints are very, very pain sensitive. Let's move forward. Look at the capsule. We always thought that a capsule is a simple ligament, but the capsule has many mechanoreceptors. It has posterior corpuscles, and they found out that the capsule by itself can generate pain by secreting substance P, prostaglandin, bradykinin, and calcitonin-regulated peptides. Thus, by itself, you will find out that the joint of the capsule by itself is very, very pain sensitive and pain generating. Now, when you look at the circulation or the innervation of the facet joint, you can find that it is very, very richly innervated. That's why sometimes by doing facet blocks, you can reduce the back pain of the patient. What are you doing? You are actually numbing these nerves around that area. You're actually destroying the capacity of the facet joint or the capsules to produce those substances that can initiate inflammatory processes. That is why you can do dorsal rhizotomy as a surgical procedure. You can inject steroids over the facets, no? Or you can do procedures that will block the nerves to be able to take away the pain generated by the facet joints. That's another treatment modality, but that is already invasive. Okay? Now, let's go to the spinal cord. The spinal cord, of course, is a very special structure. It is a structure that connects the brain and the rest of the body. As you can see, the spinal cord, as it goes down, divides into the dorsal rami and the ventral rami to create the nerve root. Is the spinal cord and the nerve root pain sensitive? That is a question that is always asked of residents as well. You might be surprised that the spinal cord and the nerve roots are practically pain insensitive. You can manipulate the spinal cord, you can manipulate the nerve root without inducing pain. How would you know that if the patient is under general anesthesia? Well, we know because if you manipulate a very painful part of the body while the patient is under general anesthesia, you'll find out that their blood pressure goes up, they become tachycardic, meaning to say that even under deep sleep, patients react to pain. When neurosurgeons tinker with the spinal cord and the nerve root, the anesthesiologists don't register any pain at all. However, I want you to look at this. This is the dura over here, and that is the dura over here because this is an open spinal cord. The dura is very, very pain sensitive. Now, it is not at all that the nerve root is pain sensitive. You have to realize that the dorsal nerve root, this one, the dorsal nerve root, is very, very pain sensitive, especially beyond this area where you have the ganglion. Now we have introduced a new word, the ganglion. What is a ganglion? That is the dorsal root ganglion. You have the dorsal sensory efferent, no, going to the spinal cord, and the ventral is the one that's afferent. So efferent means to say it brings the sensation from the skin, from the musculotendinous area, from the intestines, the base of the body, to be able to be interpreted by the spinal cord and goes up to the second order neuron, to the third order neuron of the brain. Because the dorsal root ganglion contains 16 to 20,000 first order neurons, meaning to say that they will be the first one to interpret any pain sensation that will be registered from the skin, from the muscles, from the viscera of the body. And then goes in the spinal cord to the second order neuron, to the third order neuron of the brain. The ganglion is very important because it is where everything is synthesized and interpreted before it goes to the brain. Now, look at this. This is a very nice illustration that I would like you to remember and probably take a picture in your monitors. That is the dorsal root ganglion. Okay. That dorsal root ganglion is very important because look, that dorsal root ganglion has mechanosensitive receptors that reacts to mechanical, chemical, thermal, and noxious stimuli. It has one purpose, nociception. And of course, we know what nociception is, pain perception. It is endowed by thousands of presynaptic control, mostly by GABA A. There are two GABA receptors, GABA A and GABA B. GABA A receptors are ligand-gated ion channel receptors. When you hear the word ligand-gated ion channel receptors, then this picture comes into your mind. This is a presynaptic neuron, and that will be the alpha-2 delta subunit, okay, where calcium goes in to release number 2, your vesicle that contains all your neuropeptides, glutamine, glutamate, norepinephrine, substance P, calcitonin peptides, which registers pain. So if you have a ligand that will connect with your alpha-2 delta subunit, then you will be able to prevent the release of these neuropeptides. And we have been using those for a long time. Amitriptyline, duloxetine, gabapentin, pregabalin. So at our disposal, we already have so many medications that prevents the alpha-2 delta subunit to allow calcium to enter, to release these peptides to induce pain. So at our disposals, we have so many medications already that works very well for our low back pain. And again, that's a conservative management. Okay. Now going back to this illustration, I want you to center to this nerve over here. This is the recurrent nerve of Luschka, something that we don't remember anymore. It is also called the recurrent meningeal nerve or the sinovertebral nerve. What does it do? Look at that nerve. It has already gotten out of the spinal cord. And then it courses again and bends backward to enter the spinal cord to the foramen. That is why it's called the recurrent nerve of Luschka. It goes back and bends to go in again. And what does it do? It innervates the facet joints. It innervates the annulus fibrosus, the posterior aspect, and it innervates the anterior dura. Okay. Now, I want you to look at these two structures, something that we don't even give matter anymore when we do surgery. No? Those are the paravertebral sympathetic ganglia and the rami communicantes that connects the ganglion and the ganglia. What does it do? You can see the very intricate system whereby we have these nerves communicating with one another. And look at the nerve. They are all innervating the structures of the whole vertebral body unit. If you look at this illustration, it will answer for everything. You will now realize why when you have a bad disposition, you can develop low back pain. When you have low back pain, you will have bad disposition. When you have a bad kidney problem, it can cause low back pain. When you have a gallbladder problem, it can cause low back pain. When you have low back pain, it can cause you to be tachycardic and hypertensive. When you have low back pain, it can cause you to be tachypneic. It is because of the very intricate connection of our low back to the sympathetic ganglia and to the rest of the ganglion that we have. That is the reason why later on in the classification, you will understand why we have viscerogenic problems and psychogenic problems related to low back pain. Now, lastly, the neural foramina. Well, we all know that the neural foramina is where the nerve root goes out. But is it only the neural nerve root that goes out? Are there co-inhabitants of the foramen? Look at this drawing over here. You have the nerve root over there. You can see here. There's a blood vessel over here. There are a couple of nerves over here, and there are veins over here. Actually, on MRI, you can find this as the nerve root, this as the blood vessel, and those dark things over there and this one are the nerves. Those are your recurrent nerve of Luschka. Those are your nerve root. Those are the radicular branch of your sinovertebral artery. They all co-inhabit the foramen. That's why when you have a foraminal narrowing, because the disc is desiccated, and you very well know that the diameter of the foramen is dependent on the integrity of the disc, then all of these structures become compressed. And when they become compressed, they create a lot of pain because all of these structures that I've shown you co-inhabiting the foramen are actually pain-sensitive structures. That is also the reason why neuroforaminal steroid injection, wherein you direct your steroids to this area, more than epidural steroid injection works better. So when you have a choice as to give epidural injection and neuroforaminal injection, you can be sure that neuroforaminal injection works best for patients with claudication and those with sciatica. Because when you inject your steroid over the epidural area, you actually have no control as to where the steroid goes. But when you inject the neuroforaminal area, you can be very well sure that you afford the anti-inflammatory effect of your steroids over the structures of the neuroforaminal area and those co-inhabiting those areas. Okay? Now, when you have a disherniation like this, what happens? You have both mechanical and chemical reaction happening. And when we say chemical reaction, you have secretion of bradykinins, histamines, cytokines, arachidonic acid, substance P. All inflammatory peptides that causes severe pain for our patients, all causing the recurrent neuropathy to initiate pain sensation over the back. If we have ways of controlling the chemical reaction, so be it. But the point is, when we take medications, it will only work for about 4 to 6 hours. After 4 to 6 hours, when the medications has been synthesized or secreted by our kidneys, then this chemical reaction will happen again. That is the reason sometimes, for some cases, 20% of patients are candidates for surgery so that we can remove the mechanical compression that will eventually remove the chemical reaction over the area. Okay? So we very well know that pain is both biomechanical process and biochemical process, but there's one very important component that we usually forget. That pain has a third prong, and that would be psychosocial component. Psychosocial component is one thing that we often neglect. We're too preoccupied with the MRI, X-ray, CT scans, that we never bother to ask the patient about what is happening in the family or at work, because this is a pain generator by itself. All three have one Venn diagram, capital P, capital A, capital I, capital N, pain. Now, classification of low back pain. Would you believe low back pain has been around for a very long time, but they can only classify low back pain as either acute, subacute, or chronic. Mean to say the duration. 1 to 3 weeks acute, subacute 3 to 12 weeks, and more than 12 weeks is chronic. So they have gone further to revise the classification. So what did they do? They named subacute as subchronic. What the heck? And then they just added more weeks, 1 to 6 weeks acute, 6 to 12 weeks subchronic, and then chronic is 12 weeks. Meaning to say that up to now, you can very well see that low back pain is a problem that's still very, very poorly understood. Next, mechanical classification of low back pain, no? According to etiology. They say that it can be divided as mechanical, non-mechanical, and referred pain. Now we're talking business, because now they are subdividing the causes of pain as to how we are going to treat them. But look at this. Mechanical, strains, herniations, degeneration, and joint diseases. Okay, we're okay with that. Non-mechanical, tumors, infection, spondyloarthritis. But when you look at this, isn't degeneration, joint disease, and spondyloarthritis the same thing? So there's a lot of overlap over this classification, and this is very, very misleading. Yes, referred pain can be secondary to any visceral problems or vascular problems, no? But this classification by Mansov is very lacking, no? So far, the best classification that we can still use is the one that was set by McNabb and McCullough in 1978, wherein they classified low back pain according to origin as psychogenic. We have discussed that coming from our mind. Viscerogenic, we have discussed that because of its connection to the sympathetic ganglia. Vascular, that's one of the biggest problems that will happen, a misdiagnosis of an aortic aneurysm. And for patients with spinal stenosis, vascular problems with the lower back, which we usually do not even bother to see, dorsalis pedis, pulsation. And then the more very common ones affecting the nerves will be neurogenic back pain. And then the last one is spondylogenic back pain. So you can see that this at least segregates and separates the different possible causes of low back pain. And up to now, this is still the best so far that we have in terms of classifying low back pain to its origin. Now, I will be very, very prompt with you in telling you that I will not be discussing discogenic low back pain, because discogenic low back pain as a topic deserves its own webinar and lecture series. However, discogenic low back pain is something that I will mention in the next slide. When we talk about spondylogenic back pain, discogenic back pain constitutes 40% of that. Herniated disc is a special category. Anatomical pathology refers to any pathology of the anatomy that is destroyed by any diseases. Okay? So I will not be discussing discogenic back pain. I will jump to herniated disc. Herniated disc can be central. It can be posterolateral. It can be foraminal. It can be extraforaminal. So when you have both legs affected, it might be central. But when you have posterolateral, foraminal, extraforaminal affected, then you know that it's only on one side, either right or the left. But then from this drawing, you can only imagine what is happening based on the previous discussion that I have presented to you so far. Mind you, the neuroforaminal structures that are being affected when you have foraminal and extraforaminal herniations. Okay? Now, what are the other things that can cause low back pain? Just like in any diseases in the human being, there are only 5 disease categories that can affect man. We all have trauma in our life, psychological or emotional. Hopefully, none of us have congenital problems. We have all been infected in one way or another. Hopefully, in our lifetime, we will not develop neoplasm, but all of us are going to be old, degeneration. So, it goes without saying that the spine can be subjected to trauma. It can develop congenital anomalies. It can be infected. It can be affected by neoplasm as a metastatic problem or a primary problem, and of course, degeneration. Either which, when you look at the structures, the anatomy of the spine has been destroyed. And when the anatomy of the spine has been destroyed, we very well discuss what the pain generators are, and you can already deduce how pain evolves because of these drawings. Now, let's look at this. I will go on a little bit slow on this because this is a drawing that I worked so hard to be able to explain to you what happens when we have degeneration of the lumbar spine. Our attention should center on the disc. Sometime at the age of 40 for the general population, our disc will start to desiccate. When it desiccates, meaning to say that it will not absorb water anymore and that its weight-bearing capacity is not as good as it was when we were from 10 years old to 30 years old, 35 years old. Okay? So when that happens, a lot of the population might develop disc bulges like this. When you have a disc bulge like this, it is already a sign that the vertebral body will not be able to sustain, or the intervertebral disc will not be able to sustain the weight being afforded by the forces of the spine. So from 80%, about 10% or 20% are now being transferred to the posterior elements. And that is the start of a problem because when you add more weight over the facet, then you can develop facet problems already. Okay? And does this happen? What comes next? Some of the disc starts to narrow down. And with narrow downs, what happened to the foramen? Look at the foramen. It starts to become small. And when the foramen becomes small, so what happens? We know that there are elements passing to that, and they will be compressed. And look at the edges of the vertebral body. They develop osteophytes already. Osteophytes are a sign that the body is trying to stabilize itself. When you see osteophytes on X-rays like this, it shows that there's instability of the spine. Now, I would like to drive your attention to this ligament over here, the posterior longitudinal ligament. The posterior longitudinal ligament is a very important ligament because it's an elastic ligament. When you bend forward to pick something from the floor in a young individual and you try to stand erect again, it is the posterior, is the ligamentum ligament that actually springs you back to an upright position. And there are very minimal muscles firing to push you back to erect position. The elasticity of the ligamentum flavum is affected when you have a problem like this. It's just like the garter of your panty in your briefs. It starts to bacon up like this because it loses its tension. Okay. So as your stenosis progresses, the intervertebral foramen narrows and as well as spinal canal narrows. Okay. And look at the facets. The facets hypertrophy to the point that it becomes like this, where your neuroforaminal stenosis is very evident and your central canal stenosis is very evident. Now, as to how the pain generates, I guess from the previous discussion that we have, you can already imagine the mechanical and biochemical reaction that are happening when you have a spine like this. Okay. Now, we have a myriad of clinical symptoms. No? I'm very close to the end of the lecture. We have low back pain as the general pain. We have radicular pain, claudical pain, deformity, weakness, and bowel bladder symptoms. As you can see, this myriad of symptoms have been divided into 3 white letters: low back pain, radicular pain, claudical pain, and 3 green letters: deformity, weaknesses, bowel bladder. Why? Because the first 3 are subjective complaints, and the last 3 are objective complaints. Subjective means to say that we don't see anything. It is related or told to us by the patient. We don't know if it is true or not. We just have to take their word for it. But we have to listen to those things. Because when we have subjective symptomatic forms of back pain, radiculopathy or sciatica, and claudication, they do have anatomical basis. When you have back pain, it's usually secondary to irritation of the periosteum. It can be facet irritation, It can be very well capsule irritation from what I have lectured a while ago. And there's one thing that we keep on forgetting. The muscles, the dynamic stabilizers that we have, they have a big part in developing pain syndrome, myofascial syndrome, fibromyalgia. And when you have back pain, usually it denotes structural instability as well. When you have radiculopathy, you have nerve root impingement. And when you have posterior rama irritation, it also causes sciatica. Claudication is when you have venous stasis because of the narrowing of the intervertebral foramina, wherein the radicular artery could not supply the nerve anymore. You have poor CSF flow, and sometimes compression of the cauda. When we talk about the three objective symptoms, deformity, weakness, bowel bladder, and cauda equina, we have objective findings. We can see that they have deformities, that they are crooked. We can see from our examination that they have weaknesses. And we can see that they are in a condom cut, no, and they are in a pampers and they have bowel bladder syndrome. Okay? And what causes this? Deformity can be secondary to existing scoliosis or de novo scoliosis. It can be secondary to spondylolisthesis or what has been lectured a while ago, osteoporotic vertebral compression fractures. Weaknesses can be secondary to cord impingement and nerve impingement. And of course, when you have cauda equina, you know what the problem is. Now, this is the spectrum of lumbar spine degeneration, from normal on the far left to deformity on the far right down. Let's discuss it in a very, very short segment. Okay, this is a normal spine. You can have a herniated disc. You very well know how it can cause pain from our previous lecture. Okay, this can develop also to spondylosis. As you can see, the disc space has narrowed. The flabum has buckled. That's why you have a herniation here. And the facet here has hypertrophied compared to the rest of the facet over there. Okay. It can develop to multifold instability wherein you develop stenosis like this and you have your osteophytes here. It's nice if you have the osteophytes in front, but that also irritates your ALL, your anterior ligament. And it's bad when you have osteophytes at the back. Okay. You can have a spondylosis like this that can progress to a spondylolisthesis. This is a deformity that is also very disabling because it causes central canal and neuroforaminal stenosis. Okay. You can have osteoporotic vertebral compression fracture like this that can develop spondylolisthesis as well and can form very, very bad deformity like this. All in all, you can see that the etiology of low back pain by pathophysiology is both nociceptive pain, secondary to injury to the anatomy, and neuropathic pain because of injury to the ganglion and the rest of the structures that are supplied by the ganglion. And when you have nociceptive pain and neuropathic pain, that creates a mixed type of pain. A mixed type of pain, no, is something very bad because a survey of 8,000 patients with chronic low back pain revealed that 37% of them have neuropathic pain. Okay. So this last part of my lecture, at least here's hoping that we have a sense of what low back pain is. It is complex. It is something that cannot be covered by just one webinar lecture. It is something that we have to discuss on a whole day basis, a whole conference on low back pain. And about discogenic low back pain, I hope there will be one lecture solely on discogenic low back pain. Thank you very much.
Thank you very much, Dr. Bundoc, for a very detailed lecture on an introduction alone for low back pain. Low back pain is truly a big problem. And as you said earlier, it's one of the more common complaints for our patients today. Now, please log your questions at our website at this point in time. May I ask the first question, Dr. Bundoc? When you earlier enumerated the low back pain generators as varied in different varied causes, what is your approach to find out which pain generator is the one that is causing the back pain for your patients?
One that we will always tell our residents and our students is a very, very meticulous physical examination. Aside from physical examination, we have to take time to listen to them. The problem is sometimes we do not listen to our patients anymore. Like for example, pain. Pain is very important because we have to ask them the spatial relationship to pain, when it happens, how it gets relieved, and what maneuvers do they do to have relief of the pain. We have to ask them how it is when they wake up in the morning. Is it very easy for them to spring out of bed? Or do they have difficulty? It takes them minutes for them to get out of bed. Those are totally different things. Okay? And when they have low back pain, most of them will have both low back pain and radicular pain. We have to quantify which is more. Is it more of low back pain or is more of sciatic pain? If it's more of sciatic pain, the job becomes a little bit easier. But when you have more low back pain, then we have to be very, very cautious. So physical examination and history is very important. And then sometimes you're still at a loss because the MRI shows this and the CT scan shows that and the exercise shows this. No? We can do provocative tests like facet blocks, neuroforaminal injection, or even discography, so that we'll be able to ascertain as to really what the pain generator is. Because the worst thing that can happen is to subject the patient to an invasive procedure and the patient goes back to you with no relief at all. So always maximize conservative management before we go for the invasive ones.
Thank you. Additionally, you lectured on the different subjective symptoms of our patients. And I might put you on the spot here, but you enumerated back pain, radiculopathy, and claudication as different subjective complaints. Which one do you think is the easiest to treat among all three?
Among all three, I'll go for something that has an objective basis because you very well know that there's an anatomical structure that is being affected. Now, with regards to pain, pain is subjective. I can make up a low back pain and not join an excursion. I can make up a low back pain and not join a conference. I can tell my boss, Dr. Wang, that I cannot do a webinar because I have a low back pain. And they will never really know if I have a low back pain or not at all.
Yes. So let's look at the questions that have been sent so far. And yes, regarding lumbar spondylosis and the degenerative cascade that you were explaining a while ago, they were asking about the new bone formation that is associated with this and how does it really affect the stenosis on our patients.
The good thing about this new bone formation is that most of them grow either anteriorly or laterally. Why? Because somehow the body senses that there are very important structures at the back that they should not be banging on. No? But you see also patients with posterior osteophytes. No? But the problem is the osteophytes of the joint or the facet joint. They can go anywhere they want to go. They can be very, very hypertrophic and create big lateral recess stenosis, and they can be very, very big to obliterate the neuroforaminal as well.
Yes. One last question from one of our viewers here. One of our participants is asking, what are the treatment options for failed conservative management of the slip disc?
When you have failed conservative management of slip disc, it's about time that we discuss possibly surgical intervention for patients, no? And make them realize that we have maximized our conservative treatment, and thus the only possible course of action is to plan out surgery ready. But that will be a long discussion with the patient as well.
Again, thank you very much, Dr. Rafael Bundoc, for a very good lecture today. I think we have successfully completed our first webinar for August. And may I remind the participants to please make sure that you log on so that you can get the credit, your CPD credits. And see you again next week, same time, same website. Signing off now.